Do you suffer from shoulder pain? At some point in their life, 70% of people will suffer with some sort of shoulder pain. Now, when we talk about shoulder pain, that can mean a lot of different variants, but today what I'm going to do is go over a brief review of the anatomy of the shoulder, talk about the mechanics of the shoulder, and then talk about some of the most common shoulder symptoms that can cause pain and can really lead to debility. There's millions and millions of dollars that are lost every year due to lost revenue, due to lost work, surgery, which we'll talk a little bit about, and how 4 out of 5 patients that we see in our clinics end up not needing surgery, and we'll kind of talk a little bit about that and how that kind of comes around. There are certain percentage of the population that will need surgery, but we can usually determine that after a very thorough initial evaluation with one of our physical therapists. Hi, I'm Dr. Steve Ryland, physical therapist, 29 years practice experience, most in orthopedic sports medicine, and owning private practices for the majority of my career. When we talk about shoulder pain, the average person waits after first experiencing shoulder pain for almost a year before seeking treatment. And that's something very common that we see with back pain, knee pain, shoulder pain. We have that wait and see mentality when really 50 states now allow direct access to physical therapy. If you have shoulder pain, my suggestion is don't wait. You don't need to go out and get an x-ray. You don't need to get an MRI. Call your local physical therapist, get an appointment, get in there, get treated, reduce that symptoms, get back to work, get back to doing active sports, whether it be weightlifting, tennis, golf. We see a lot of golf players that have shoulder pain, and there's just no need to sit and wait. Get it taken care of immediately without having to suffer. Let's go over a little bit of the anatomy of the shoulder. So one of the things with shoulder, what we see is, usually when people have shoulder pain, it's reaching above shoulder height, anything above that shoulder height. And the reason for that, the shoulder is one of the more complicated joints in the body. So what we look at first is we have the shoulder blade, or what we call the scapula. That scapula sits up against the rib cage. Then you have the main shoulder joint, which is the glenohumeral joint, which is the upper arm bone, which is the humerus, and then a bone that comes off the shoulder blade called your acromion. That's a ball and socket joint. So the upper humerus is the ball, and then the acromion that comes off the shoulder blade, that's the socket. Now, 2 structures run between that joint, one of them being the supraspinatus. People talk about rotator cuff injuries. The most common source of shoulder pain is shoulder impingement, and that is where the supraspinatus, which is one of the 4 muscles of the rotator cuff, which runs right between that ball and socket. If you look at a patient, you can see the supraspinatus comes right on the top port of the shoulder blade. It originates from there, and then it ducks down in between that socket and then inserts on the upper arm bone, the humerus. Its job is to seat the humerus up into the joint, and it's also an abductor. It helps you to reach out to the side. That muscle, because of its proximity of where it runs, and then you also have a little bursa called the subacromial bursa that will sit. It's a little fluid-filled sac to prevent those 2 bones from kind of bumping up each other. But when you go to reach up above shoulder height, if your scapula or your shoulder blade is not moving properly, then what will happen is that muscle and that bursa will get pinched. Repetitively over time, that'll lead to pain, it'll lead to a lot of suffering. Patients will say, I roll over and I sleep on that side and I get a lot of pain, it wakes me up at night, or if I go to reach for something in the cabinets, I get this sharp stabbing pain, or if I go to tuck in my shirt, or if I go to put my seatbelt on, I'm getting this sharp pain in my shoulder, but it kind of comes and goes. If gone unchecked, that pain will turn into chronic pain, and then eventually, if you let it go too long, from that repetitive motion, that's where you can get a rotator cuff tear. Most patients that come into our office, if you have a rotator cuff tear, it usually means that the supraspinatus is partially torn, and if it's 50% or less, that's treatable in physical therapy. I've even seen some people who have a full thickness rotator cuff tear, meaning that supraspinatus is completely torn, and they have full function and full motion. But there's some very simple tests that we can do, and we can tell, even without having the MRI, What degree? Is it impingement? Is it partially torn? Is it a full thickness tear? Usually with a full thickness tear though, you will start to see atrophy in that supraspinatus. So if you compare the two sides and look and palpate that supraspinatus, you can start to feel where that muscle tissue, and on our patient here, he's got good development of his supraspinatus. They look pretty equal bilateral, but you can also see the shoulders are kind of forward, you know, and everything we do today, whether we're on a cell phone, whether we're on a computer, if you look at a 3-year-old, they have perfect posture. After 3, our shoulders start to round, our heads start to go down. We have cell phone-itis, we have computers that we're working on all day. Totally different subject. There's another YouTube video that I put out about posture, and you really want to work on pulling those shoulder blades and that posture back, because that humeral head, like we talked about, ball and socket joint, that humeral head will move forward because the shoulders, and now when you go to lift your arm up over your head, you get even more impingement. So it's really important, posture, posture, posture. But for today's purposes, we're gonna say this is a patient that has a little bit of shoulder pain. It's their right dominant arm. They come in, you know, reaching overhead, trying to tuck in their shirt, reaching behind their back, reaching out to the side, putting on their seatbelt, and then just general, you know, sleeping, rolling over on the shoulder. It hurts, right? Don't need an MRI yet. Don't need an x-ray yet. We'll treat it conservatively with physical therapy 4 to 6 weeks, teach you some strengthening exercises, teach you some stretches to do, because the pec muscles, the muscles in the front of your chest, tend to get tight. So you want to stretch those out. We want to do some strengthening exercises for the rotator cuff. And again, going back to the anatomy of the shoulder blade and that rotator cuff, you've got 4 muscles that make up the rotator cuff. We call them the sits muscles, S-I-T-S. Supraspinatus, one we already talked about, the most common injured, either torn or impinged in shoulder pain. You have the infraspinatus, which sits underneath that. Then you have the teres minor, and then you have the subscapularis, which sits on the back side. You can't palpate that one from here, but it sits on the back side of the shoulder blade. Collectively, those 4 muscles make up the rotator cuff. So when somebody says, I have a rotator cuff injury, that's very generic. It doesn't mean anything. It just usually means the supraspinatus is involved in some sort of either impingement or a tear. Usually when people tear the supraspinatus, it's because they fell on an outstretched arm. They were in a motor vehicle accident. We see that a lot with motor vehicle accidents, with people gripping the steering wheel. The force is driven right up into that shoulder and that supraspinatus tears. Or repetitive, you know, tennis players, golf players, repetitive motion will eventually, if you don't get it treated conservatively, eventually that rotator cuff, that supraspinatus, will tear to the point where it needs to go in and be surgically repaired. And that's a lot of time down, a lot of time of not using the shoulder. It's in a sling. You really can't do much for 12 to 16 weeks, depending on the severity of the tear. But a little bit more on the anatomy. So when you go to lift your arm up over your head, so go ahead and lift your right arm. Here, let me go ahead and put it back down. Thumb up, straight in front of you. I want you to try to lift it straight up. So you can see, okay, and back down slowly. You'll see how that scapula, now on him, you can kind of see that. There is a little bit of dysfunction in that shoulder. Go ahead and slowly start lifting it again. You see where that shoulder blade starts what we call winging, and then it kind of takes off a little soon. So at some point, he may have had some dysfunction in that shoulder. Are you having any pain? Okay. So it's asymptomatic, but this is somebody that actually would benefit from some skilled physical therapy. I know personally that this patient's had some neck problems. Most of it's been on the left, but he's also had some right side, some degenerative disc disease. We always want to clear the neck, because that neck, the nerves that come out of this, what we call the cervical spine from the base of your skull, the first 7 vertebrae down to here, those nerve roots, go ahead and lower your shoulder back down. Those nerve roots will come out to form what we call the brachial plexus, which then divides into the 3 nerves that go down the shoulder. Now those nerve roots, if they get impinged from a disc or degenerative disc disease, those muscles of the shoulder, particularly the shoulder blade, will start to atrophy. And you can see on him, most notably on this right side, you can see that medial border of the scapula. Here's his spinal column. You can see how that scapula is already kind of way out to the side, not so much on the left, but watch when he goes to lift his arm up again. Go ahead and slowly. You'll see that shoulder blade kind of take off a little bit early, and you'll see it kind of winging a little bit. And you can actually hear when he goes to lift his shoulder, you can hear a little bit of clicking and popping. Most notably, that's probably the clavicle. Go ahead and put it back down. So again, you have the bones that make up the shoulder blade, and there you saw that winging again as he came back down. You have the shoulder blade, you have the acromion, which comes off the shoulder blade, the humerus, and then you have the clavicle. And where the clavicle comes in, that clavicle, when you go to, and you've heard of people that have fractured their clavicle, etc., when you go to lift your arm, that clavicle has to roll backwards, and then as you lower it down, it rolls forward, so you can get a little bit of arthritis in there. And typically when they go in to do a shoulder surgery, they're going to clean up all that arthritis. They'll clean up the arthritis on the humeral head. They'll do what they call a distal clavicle resection, where they'll cut a little bit of that clavicle off. They'll do a subacromial decompression, where that acromion that comes off the shoulder blade, they'll kind of cut that up a little bit, and then they'll go in and repair the rotator cuff if it's torn. But typically, you know, what we see, 75% of our patients that come in with shoulder pain, they don't need surgery. We treat them 4 to 6 weeks. We do exercises, we do stretching, we teach them posture, we teach them body mechanics, we lift them, teach them how to lift correctly, etc. And usually after 4 to 6 weeks, it holds. If they keep doing their exercises at home, if they keep icing it, this is where a good ice pack, I always say, if you have pain, ice is your friend. Icing it 2 times a day for 10 minutes, put that ice pack, which is on our, if you go to our website and hit our product link, the ice pack that we recommend, the Chattanooga, that's on the website. You can look at some other products, etc. But in summary, shoulder pain, A, it's very treatable. B, you need to come in as soon as possible. Please don't wait. When you have any pain syndrome whatsoever, pain is your body's way of telling you something is not correct. Whether it's posture, whether it's anatomy, whether something's going on in your body, but pain is not normal, and pain needs to be addressed and needs to be treated. The longer you wait, the more your body responds to that pain, and you start to develop other issues down the road. So pain is not good. The whole wait and see theory, that doesn't work. Get in to see your physical therapist. We have direct access. Give us a call. Get in right away. Get evaluated. That physical therapist will give you exactly what's going on with your body. We'll be able to tell if we suspect there's anything else going on, if we think we need an MRI, if we think we need an X-ray, we'll send you to your doctor. We'll get that taken care of. But let's treat it conservatively with ice, exercise, education, posture, body mechanics, all of that stuff works. So hopefully you got a little bit out of this video. The number one thing being, you know, usually we have the impingement syndrome going on in the shoulder just because the shoulder blade is not moving symmetrically. You've got some muscle weakness in that shoulder blade that we can address conservatively with physical therapy, get you much better, get that pain reduced, get you back to sleeping, getting you back to playing your sport, etc. But again, shoulder impingement being the most common form of shoulder issues that we see in physical therapy. If you got something out of this video, please like the video and also share it. Subscribe to our YouTube channel. We really appreciate it, and we'll have more information coming forward. But again, you know, clear the neck, look at the shoulder, diagnose it, get it treated, get it fixed, get you back into living a pain-free lifestyle. Again, I'm Dr. Steve Ryland, physical therapist. We appreciate you spending the time today to watch this video. We wish you all the best activity, pain-free living, and we'll see you soon on the next video. We appreciate it. Thank you.